name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis, where I'm a professor of radiation oncology, director of clinical trials, and chief of the cardiothoracic and stereotactic radiation services. With the advent of new radiotherapy options, it's natural then to start to ask questions about using these new technologies for old situations. And one of those situations is the use of SBRT for patients with limited stage small cell lung cancer, because of the extraordinary success we've had with early stage non-small cell lung cancer. I think before we can really talk about SBRT though, we really need to understand that limited stage small cell has a tremendously wide range of patients that could be categorized as limited stage. If we use the classic VA definition, limited stage merely refers to the ability to encompass the full extent of known disease within a single radiation field or portal. As such, this means that stage 1, stage 2, and technically stage 3 are all then potentially limited stage. Now, really what we're talking about then is the situation where it's more limited. SBRT, also known as SABR, uses precision high-dose focused radiation to give few doses to a small area in the body to ablative doses that have higher local control than you might achieve with a longer course of small doses per day with fractionated radiation. As such, inherently, it's really only appropriate to use for management of the primary lesion in the lung, and is therefore not really appropriate for patients with regional disease. And while there are studies looking at lower doses of SBRT in those situations, really that's in a prospective research study at this point. Now, likewise, SBRT is most appropriate for smaller lesions, typically 5 to 7 centimeters at the outset, and really isn't currently widely used for larger, bulkier lesions, given the potential risks associated with those high ablative doses to large areas of the lung. So, with this definition of mind, SBRT might instead be thought of as an alternative to surgery for early stage small cell, with all the usual caveats and one important distinction. Now, importantly, in patients who undergo primary surgical resection for early stage small cell, an optimal surgery would include management of the primary and a high quality lymphadenectomy to define the extent of nodal disease. In these cases, margin status of the primary, presence or absence of pathologically proven nodal disease, defines that need for mediastinal nodal radiation. Importantly, well, chemotherapy should be delivered in all patients whenever possible, given high rates of regional and distant failure after local therapy alone. Retrospective data for surgical resection of early stage small cell suggests that adjuvant radiation to the mediastinum and primary is most beneficial for those patients with positive margins in N1-2 disease. It's important to make this comparison because with that in mind, there are two important caveats for considering SBRT. First, SBRT is typically considered for medically inoperable patients. And second, patients treated with SBRT are typically staged primarily with PET-CT alone without the benefit of lymphadenectomy, and therefore at risk of occult mediastinal nodal disease not detected by lymph node dissection. So the second of these issues could in theory be addressed by considering a comprehensive EBUS-FNA, even in the setting of a negative PET-CT, just because the rate of occult nodal disease is so high for small cell. Now, while the relative value of a comprehensive EBUS-FNA versus lymphadenectomy is the subject of considerable debate, in a medically inoperable patient where SBRT to the primary is being considered and a true lymphadenectomy is not feasible, I think an EBUS-FNA is reasonable to consider. Overall, the data for using SBRT in lieu of surgery is even leaner than there is for surgery alone, and is comprised primarily of small case series. There was one recent systematic review by Rathaud et al. At the University of Manitoba. They looked at 7 studies and found that generally speaking, the reason for using SBRT was unsuitability for surgery or refusal of surgery. Now, there were variable patterns in terms of the timing and sequencing of chemo and SBRT, but in general, within those reported series, 2-year survival ranged anywhere from 40 to 70%. And distant METs, not surprisingly, was the most common pattern of failure, ranging from about 40 to 50%. There didn't seem to be a significant increase in toxicity by using SBRT, at least compared to historical controls. So acknowledging these limitations, I think that this paper and others would suggest that in select patients with early stage small cell lung cancer, particularly if you can do an EBUS-FNA to prove that they had no negative disease, may in fact be a candidate for SBRT as an alternative to surgery.